Okay, I think it is 11 o'clock time in the Midwest, in in Kansas City, to be exact. I would like to start the program to keep us on time and to make sure that we also finish on time. It is my privilege to have you joining the first speaker educational program for our society, the Society of Egyptian Pathologists in North America. I am Dr. Osama Taufik, Professor and Chair of Pathology at the St. Luke's Health System in Kansas City, and having the honor of being the president of our newly formed society. And before the introduction of our guest speaker, I would like to have a few words talking with you about the society and its goals. As we call it, SEPNA for abbreviation, is our first, up to my knowledge, our first Egyptian pathology organization in North America and probably in other countries other than our beloved Egypt. It was established just recently in 2024 as a nonprofit academic educational activity to serve as a platform to enhance education, research, and professional development of primarily Egyptian pathologists and trainees in the US, in Canada, and in Egypt, as well as in other parts of the world. We're hoping to expand our reach to our colleagues everywhere. With that, I would really encourage you to have other colleagues, trainees from Egypt and other parts here in the US and Canada, that they can join us and participate in this academic fun endeavor that I believe you will find it valuable and helpful for all of us. It is my privilege and honor to introduce my dear friend and one of the best in the field, Dr. Shabaik. He is a colleague and a professor of pathology at the Medical School of the University of California in San Diego, and the attending surgical pathologist and cytopathologist at USSD Healthcare. Dr. Shabaik is a graduate from my alma mater, the University of Cairo Faculty of Medicine, a couple of years before mine. In 1976, soon after, he moved to the US, where he finished his residency training in anatomic and clinical pathology, followed by fellowships in surgical pathology and cytopathology. Dr. Shabaik is a diplomat of the American Board of Pathology in anatomic and clinical pathology and cytopathology. He has been at UCSD School of Medicine since 1992, teaching medical students as well as residents and fellows. And I am sure you will find him very knowledgeable and one of the best in the field. The title of his presentation is The Gleason Grading System from the 70s to the ISUP and GUPS. I would like to learn more about GUPS myself. Hopefully you will enjoy it and learn from it and get up-to-date, wonderful information that we all can use in our practice. Before I leave him taking care of the lectures, I have a few housekeeping announcements that I appreciate your help with. Please mute your speakers. Questions will be sent through the chat box found on the right side of your screen. The moderator, i.e. me, will try to share them with the speaker at the end of his talk. This is to avoid interruptions. We will try to finish on time. This lecture is, as you notice, recorded and will be uploaded on the Society's website and our YouTube channel for your convenience and further reference. We would love to have your feedback to improve our experience. We just started this program, so I'm sure we need a lot of help. Also, we appreciate your spreading the word about the society and having your colleagues join. Without further delay, I pass the mic to Dr. Shabaik to listen to his wonderful lecture.
Good morning. شكرا دكتور أسامة وصباح الخير للجميع. I hope inshallah this will be a kind of enjoyable lecture and will help with your practice to understand some of the historical background of the Gleason grading system and how it evolved from the 70s till now. So the the histologic grading for prostate carcinoma actually started from I don't know, it's asking me to join. Okay. The histologic grading of prostate carcinoma started from the studies of this group named Veterans Administration Cooperative Urological Research Group, for which Dr. Gleason was the reference and lead pathologist. The studies were prospective, controlled, randomized, and started in 1960 and continued until about 1975. The system was first introduced in about 1966 with modifications 67, 1974, and 1977, and usually continued to evolve after that. And even Dr. Gleason, I had the pleasure of seeing him and meeting him in one of the ASCAP meetings around 2006 or 7, when he kind of, after the first ISUP modification for the system, where he gave a talk about Gleason on Gleason. And I think from my recollection, I think he was not very happy with the kind of the modification that have happened. But we're going to see now the system. So Dr. Gleason, from his observations on prostate, so many cases of prostate biopsies, was able to find about 9 architecture patterns in which prostate carcinoma can manifest. And he's in this kind of his hand drawing here. He shows like about 9 patterns. And these 9 patterns kind of from pattern 1, that would be the most differentiated, and pattern 9 would be the least differentiated. And he grouped these 9 patterns from based on his kind of observation and correlation of the pattern with the outcome. He was able to put these 9 patterns into 5 prognostic groups. And group 1 had pattern 1, group 2 had pattern 2, but group 3 had subpatterns, and group 4 had subpatterns, and group 5 also had some subpatterns. These are some of his first kind of applications in about the prostate carcinoma and clinical and pathological correlation and with the introduction of the system. This one is from 1974 when he kind of illustrated some of these five groups by some of these images. We're not going to go through that, but these are like just to historical kind of value. Now, in 1992, in Human Pathology, Dr. Gleason wrote this paper as a perspective on the at that time still it was not called the Gleason Grading System, but was called the prostate histologic grading of prostate carcinoma. People later on named it Gleason Grading System and the Gleason score. So he did not give it his name, but the name was given to the system, or the Gleason name given to the system, because he is the one who kind of the major factor of, after or behind developing that system. Let me see if we can. Okay, sorry. Did I lose the? Okay, no, let me see. I lost something here. Yeah. Okay, so now he in 1992, after about 15 years from the development of the system, 15 years from development of the system, he noted there was some kind of not misuse, but people were not using the system correctly. And he wrote this paper in Human Pathology, and in which he again introduced the system again with these kind of that diagrammatic representation of the five grades. And grade 1 and grade 2 and grade 3 had sub-patterns, called it A, B, and C, and 4 had A and B, and 5 also had A and B, as you can see here in this table. And he's giving like the description of each kind of pattern here. So I think this pattern and this system is known to everybody. I'm not going to go over that much, but he also said that the system was based on low power evaluation, which is 4x or 10x only. Don't use high power, otherwise you're going to be overgrading the system. And he also noted that most prostate cancer can show more than one grade. And the two most prominent grades, the primary and the secondary, were added to create what he called the histologic score, which now called Gleason score. If only one grade existed, then the Gleason score or the histological score was double the value of that grade. And so the possible scores were like from 2 to 10. And in their studies, they found that the score had the strongest correlation with behavior of the tumor more than any other parameter of malignancy. You can see here the solid bars here represent death from carcinoma of the prostate, and the hatchet bars represent death from all other causes. So even with that, you can see with high-grade carcinoma of the prostate, Gleason score 10, still men can live with it and die of other causes. Maybe about, I can say like 30 to 40% of patients with high-grade carcinoma can still live with it and die from other causes. So he noted that people started lumping the grades, and they did like grades 2, 3, and 4. These call them low grade, well differentiated, 5, 6, and 7, intermediate, 8, 9, and 10, poorly differentiated. So I think also one of these, the prominent pathologists at that time who kind of did not like very much the Gleason grading system and was sticking to well, moderate, and poorly was Dr. Mustafi of the AFIP at that time. Gleason said 3 groups of 3 have an appealing symmetry. However, lumping may conceal useful information. And he said the central group, which is 5, 6, and 7, lumps tumors of very different behavior. In fact, the 3 most critical histological scores are buried in this group. And he said it would be preferable to lump scores 2, 3, and 4, 2, 3, 4, and 5, and keep both 6 and 7 separate, and then the third group would be 8, 9, and 10, which is kind of very similar to what we do nowadays when we see the progress of that Gleason scoring system. And this is usually quite feasible since scores 6 and 7 are the most common scores among clinically diagnosed tumors. And he said if the goal is to compare some parameters between good and bad, tumors, then it would be best to establish two groups, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And I believe group 6 here, when we're going to see probably the 6 of Gleason time or Gleason era probably corresponds to 7, 3 plus 4 that we use right now. And maybe the 7 here probably represents like the 4 plus 3 cancer. So it kind of reflects also his insight into what's good and what's bad in prostate cancers. So after 40 years from the use of the system, there has been kind of time to reflect back on the system and see probably it's time to make some changes to the system to adapt to the changing landscape in the practice of urologic practice as well as pathology practice. During that time, the PSA was introduced as a screening tool in the 90s. And I think before that, the digital rectal exam was the probably most common thing or most used screening tools to check for prostate carcinoma, which is, as you know, everybody, it's kind of very non-specific and not sensitive. So also the development of needle core biopsies kind of also coincided with the introduction of PSA, and that led to a widespread use of the needle core biopsies with immense numbers of biopsies at that time. Also, the prostatectomy procedure had much more advances than we used to we received better specimens, as well as we started wider sampling of prostatectomy specimen, and to find multiple tumors maybe unrelated to each other within a same sample. And then also there was the description of variants of prostate carcinoma patterns that were not kind of depicted by Gleason. I'm sure they were present there. They are not newly developed, but it's there, but maybe he lumped them under other patterns. Also, the development of immunohistochemistry and the introduction of basal cell markers was also another factor that made it prime time to start looking back again on the system. So the first modification came from ISUP, which stands for the International Society of Urologic Pathologists, a group of pathologists from the United States and Canada and Europe and Netherlands and Australia. This society, I think, started in the early 90s. And in 2005, these kind of, with a consensus meetings, they developed some of the modification for the Gleason system to adapt to the new development in the field. And these are the two kind of schematic representation of the different grades. And as you can see, grade 1 probably remained the same, grade 2 almost the same. They just did not allow. You can see here, Gleason maybe added maybe a few cribriform glands here in 2, but these were removed. In Gleason grade 3, they, as we're going to discuss, they allowed with some restriction some of the cribriform. 4 and 5 pretty remained about the same. So grades 1 and 2 tumors almost remain similar to the original description by Gleason, except that they should be confirmed by absence of basal cell layer using immunohistochemistry for high molecular weight keratin. At that time, we did not have PIN4 yet, but we had high molecular weight cytokeratin, which is called keratin 903. And you can see in this one here, this kind of well-delimited nodular lesion is devoid of basal cells in comparison to the benign glands. Here we can see the basal cells. As I said, also that did not allow any cribriform in pattern 2. Pattern 3 for the ISUP was restricted to discrete glandular units that may vary, may infiltrate between non-neoplastic glands with marked variation in size and shape. And they added that the presence of small to very small glands, which must not form chains, cords, is still ISUP grade 3, and that was corresponding to Gleason grade 3B. And in the Gleason grade 3C, in which there was some cribriform pattern, they restricted that one to small, uniform, well-circumscribed glands that are also in the word small, I think it was kind of described as the caliber or the diameter of these glands that are filled with this cribriform growth is not larger than normal sized adjacent glands. So they restricted that pattern very well, very much on Gleason on the ISUP grade 3. The red text here that tells you that this is probably will be a feature that will be modified later on in subsequent modifications to the system. ISUP grade 4, similar to the original, included 5 patterns: fused microacinar glands, poorly formed acini, again, large cribriform glands without necrosis, and maybe small cribriform glands with irregular border. To allow it in pattern 3, it had to have very smooth, regular border, and the size also was small size. But here, a small size, if it had any irregularity in the border, that would belong to grade 4. Also, the Gleason's hyperinflammatoid pattern. And again, that terminology changed later on, but the pattern is still the same. I think that for the new pathologist, they don't know that the old name for clear cell renal cell carcinoma was hypernephroma, or several kind of defunct theories. But the term now is clear cell renal cell carcinoma. So we can say that this one probably belongs to the grade 4, based on these are like sheets of cells with clear cytoplasm and maybe low NC ratio. It may occasionally have some gland formation, as we see also in clear renal cell carcinoma. You can sometimes see like tubule formation or gland formation. So it's remained pattern 4. And that corresponding to Gleason's pattern 4B. And then ISUP grade 5 was very similar to the original Gleason grading system, with maybe sheets of cells with no gland formation, maybe solid clusters, and cribriform or solid, or any pattern with necrosis is grade 5 right away. That's again some solid pattern with some necrosis and calcifications. So in 2005, they also put some rules that, in addition to the rules that Gleason introduced earlier, they said similar to Gleason, evaluation should be done again at low magnification. 20x lens may be used to verify the grade, but initial evaluation should never be done on 20 or 40x, because tangentially cut and small SNI you may overcall them. So it's a low power system. And they said Gleason scores 2, which is 1+1, should not be diagnosed, period, especially on core biopsies, because most of Gleason's era 1+1 tumors are now considered adenoses. And when we see that, even if they are like the basal cells, they're still very indolent type of tumors that probably one does not pay attention to them. When you have a prostatectomy that have like a tumor that maybe 4 or 3, and then you have a small focus in the particularly the anterior prostate in the transition zone, which is well delimited and have no basal cells. It's kind of a small focus of 1+1, but usually we might mention it in the comment section, but usually will not put it in the diagnosis line. And again, Gleason 3 and 4 scores, which is 1+2 or 2+2, may be done on TURB or prostatectomy, and should rarely, if ever, be made on core biopsies. And again, reiterated again the absence of cribriform pattern in grade 2. Now these are some kind of the core biopsies that I had, and then these are the ones that you wonder if this well delimited focus here of cancer, as verified here by high molecular weight cytokeratin, shows no basal cells. And you can see here basal cells in the adjacent normal glands. So is this one a possibly 1+1 or 2+1 or 2+2? So this one is because you don't see the rest of that nodule. Most likely this is a much larger nodule, but you don't see the rest of it. So it's you can say it's a 2+2 or low-grade cancer. But I think now, after all this kind of restriction by the ISUP not to make this diagnosis on core biopsies, I believe most pathologists would kind of resort to calling this one 3+3. Again, this is another similar situation, core biopsies, where maybe 3 nodules here and shows the same thing here, absence of basal cells like in the normal glands, and then there may be some overexpression, mild overexpression of AMACAR here because this is PIN4, and maybe you can say this tumor is infiltrating some of the benign, around some of the benign glands, so it is probably a 2+3. I have emphasized that pattern tree is composed of individual, discrete, and some of the best description that I heard about this kind of how to call it tree is that you can maybe draw a complete circle around each gland without touching the other gland. However, they allowed also very small, well-formed glands, also belong to pattern tree, and also they allowed maybe few clusters, solid cluster, because these could represent tangential cuts on the edge of some of these open glands. So this was what ISUP described how to make diagnosis of pattern 3. However, some areas like this one here were not really discussed in that 2005 meetings, like the small atrophic-like glands that you see here among well-formed glands. If this 3 or 4, and this one also here, when sometimes at the tip of the core, commonly you find some crushed glands that look like maybe some solid nest among well-formed glands. Is that 3 or 4? This was left to everybody to wonder about it, and to some people called it 3+3, some people called it 3+4, but at that time, I think that was dealt with in the subsequent modifications. Okay, and then they put some rules for carcinoma with the special features. As we said, some patterns of carcinoma were described that were not there at the time of Dr. Gleason. So they said, like carcinoma with vacuoles, foamy cells, mucinous extravasation, mucinous fibroplasia, colloid, glomeruloid structures. These should be assigned the grade of its basic pattern after subtracting the special features. Of course, may vary from one to other, but that kind of the rule you should go be assigned after based on its basic pattern. They said true signature cell carcinoma, not just vacuoles, is rare, but this should be grade 5. And ductal carcinoma, which is in old time used to be called endometrioid carcinoma, that usually arises in the area of the verumontanum, that used to be called the utricle, or the male counterpart of the uterus, is grade 4 if there is no necrosis, and if it has necrosis would be definitely grade 5. So this is ductal carcinoma, and don't mix ductal carcinoma with intraductal carcinoma, because this one is invasive, develops in these most of the time in the center of the gland, in the area of the verumontanum around the urethra. So it's a grade 4 tumor. And then also pseudo hyperplastic and macrocystic variants are grade 3. And they said the small cell carcinoma is akin to that what you see in the lung, and it should not be assigned a Gleason grade. It's a small cell carcinoma, and small cell carcinoma diagnosis is based mainly on morphology of a small cell carcinoma morphology, not even in absence of chromogranin or synaptophysin neuroendocrine markers. So that's by itself, it does not get a Gleason grade. And here you can see that vacuoles can be seen actually in a grade 3 tumor with some cytoplasmic vacuoles in well-formed acini. And you can see here also vacuoles seen in a grade 5 tumor, in which like these are sheets of cancer cells with no gland formation, maybe a few gland here or there, but at least this area looks like maybe solid and have some vacuoles within the cytoplasm. This one, I think this one is akin to the signature cell carcinoma that you see somewhere else in the body, like in the stomach or colon or the urinary bladder, in which like the cells are individual or form small kind of strands or small files and embedded in stroma. And this is Gleason grade 5. So these are not cytoplasmic vacuoles, although it's literally it's cytoplasmic vacuoles pushing the nucleus to the side to give the signature morphology. So this is grade 5. And carcinoma with mucinous extravasation, here with basic cribriform pattern, so this is a grade 4. Mucinous fibroplasia, in which sometimes when there is some mucin production, then the body as a reaction will give some fibrotic nodules like this one that may distort the gland. So you have to try to subtract this kind of distortion of the glands. Like here, this one, is it a gland or is it like has a glomeruloid pattern to it? But yeah, it's a kind of a 3. This one maybe seconds double barrel here, so it may be a 4. Definitely this is 3. So this is some mucinous fibroplasia and prostate carcinoma that, to the best of my knowledge, this one would be representing a 3+4. And this is the pseudo hyperplastic pattern, which on low power on core biopsy, it's probably might not attract your attention that this is actually malignant until you maybe go high power and see maybe some nucleoli in it, and then you do basal cell markers, and it's all devoid of basal cell markers here in comparison to the benign glands next to it. So pseudohyperplastic was given a standard grade 3. Also microcystic, in which kind of mimics the Swiss cheese appearance of the hyperplasia of the prostate. And then again, also in high power, you might see some large prominent nucleoli, not in the entire gland, but maybe in some foci of the gland, you'll see that prominent nucleoli. And then you do PIN4, like in this one, you can see there's overexpression of AMACAR, and then there is this is actually what you see here is not the basal cells. Actually, it's kind of, these are the nuclei of the cells. Okay. And then came the glomerular pattern, which was not decided as participants were equally divided between grade 3 and grade 4. Glomeruloid, as you can see here, that you can see that's large dilated gland with a kind of a tuft in it that does not touch the entire circumference of the gland, but it just maybe has like a hilum to it, and that was called glomeruloid pattern. Sometimes the glomeruloid pattern may have also some cribriform within this tuft, so it was not really decided upon at that time to maybe call it 3 or 4, so it was left. But then later on in 2014 amendment, it was moved to pattern 4. That's why it sits in red here. Also, foamy gland carcinoma. This one is sometimes also treacherous because the nuclei in these types of carcinoma are kind of like poor nuclei, kind of small, shrunken, and not all of them would have prominent nucleoli. But again, if you do the basal cell markers, they will be devoid of basal cell markers. This one here has a pattern that looks like close to cribriform pattern, so this one would be a pattern 4 after subtracting also the foamy cells that have this abundant pale cytoplasm. Now, they also wanted to address reporting secondary patterns of lower grade. So they said ignore lower grade secondary patterns if less than 5% of the area of the tumor. Like a tumor that's mostly 4 with less than 5% 3, that would be 4+4. And this rule would apply to core biopsies, TURB, and prostatectomy specimen. And I believe this rule is still valid till today, because the in the subsequent endorsements, or I mean modifications, anything that is not in red here was not changed. And then reporting secondary pattern of higher grade. So in a core biopsy, higher grade secondary pattern of any quantity should be included. Like 3 + 1% of 4 should be 3 + 4. So this one, it still remains the same. They did not talk about TURB specimens here, but I believe that would be applicable also to TURB specimen. However, on prostatectomy, ISUP required 5% or more to be included in the score. So quantities less than 5% were also controversial. So a 3 plus 5% or more of 4 would be 3 + 4 on a prostatectomy. And this is secondary patterns. We're not talking about tertiary pattern yet. That has a different rule. But 3 plus less than 5% of 4 was left to each one individual preference, 3 + 3 or 3 + 4, and that was again changed later on. Now, reporting tertiary pattern, that means that you have primary, secondary, and a third pattern that less in quantity. For core biopsies with 3 patterns, the rule is to report the primary and the highest. So 3 plus 4 plus 5 then would be 3 plus 5, although 5 is less than 4 and 3, but it would be equal to 3 plus 5. In a case with core with 2, 3, and 4 patterns, usually if 2 is not, I think this is a very hypothetical situation, never seen the same focus of tumor on a core that would have these 3 patterns, but they said ignore pattern 2 totally and call it 3 plus 4 or 4 plus 3, depending on which one is the highest or the primary. However, for radical prostatectomy, they say assign the Gleason score based on the primary and secondary patterns with a comment about the presence of a tertiary pattern because 4 plus 3 plus 5 is better than 4 plus 5. And like what you do in biopsy, but here in prostatectomy, call it 4, although if 5 is like 10, 15, 20%, as long as it's less than 3 and 4, then you should call it 4 plus 3. What did I say here? Based on the primary and secondary, and with comment about the presence of a tertiary pattern, because 4 plus 3 plus 5 again is better than 4 plus 5. However, if the tertiary pattern is less, is a lower grade, then you should ignore that one here. Like 4 plus 5 plus 3 would be 4 plus 5. Hopefully this is clear now. Okay, now also for reporting radical prostatectomy with more than one tumor nodule, he said assign a Gleason score to each dominant nodule. And here in the word dominant, they did not really describe it very well. So is dominant means the largest tumor or the one with the highest grade or the one with the highest stage. So in case of a non-dominant nodule is of higher grade, it should be reported. So when you see this statement here, it looks like when the meant by dominant may be the largest tumor that may be taking most of the prostatectomy. Like you can see here in this, like 3 whole mount prostates. In this one, there are like a nodule here anteriorly and this one here in right posterior lateral. If this one is like maybe 3 plus 4 or 4 plus 3, and this one may be a 2 plus 2, like one of those transition zone nodules that are not very significant, then this one will be to me the dominant nodule here, and that would be the one that goes into the diagnosis line, and that one maybe will go in the comment section. However, in this one here, like you see 3 nodules, probably these 3 are too close to each other, so this one should be an average of all these 3. And then if this one here in the anterior prostate, occasionally you can see very high grade tumors in the anterior prostate. If this one is a 4 plus 4, then this one you should not ignore it because it's just a smaller, but this one you should give it also a Gleason score and grade. I mean, and also as if it's stage, if it's extraprostatic or not. Now also sometimes you have like maybe multiple nodules that may be unrelated, like these 2 here. Definitely these are unrelated because they are right and left, and they did not connect in lower or higher levels of the prostate. And this also again anteriorly placed. This may be kind of one tumor, and in that level it's just a split. But you can based on their grade, then you can use this like maybe 2 dominant tumors and maybe 1 non-dominant, or maybe 4 dominant tumors, and then you give Gleason score to each one of them and a stage to each one of them. Now this area also was kind of left untouched in the 2005. Many times I use this map to map prostate cancer and see the distribution and see if the tumor that you see at different levels is the same tumor that kind of takes different shapes, or these are multiple different tumors. In some situations, you can see that the carcinoma exists in very small microscopic foci, like this very multiple small microscopic foci in the prostate that are not even related to each other. Maybe this one and this one are related, but definitely not related to these ones. This one is here and this one is there, so it's probably not unrelated. So in this situation, I will take the highest Gleason score here as the grade for the entire case. And if any one of these small nodules is crazy enough to make kind of extraprostatic extension, then that will be the stage based on that, even that different nodule, which you can see that has been the kind of the rule for the next modifications. Okay, so needle biopsy with different cores showing different grades. In the late 80s and early 90s, there was the sextant biopsies, and they used to take like 6 cores from the right side, 6 cores from the left side, and usually put the 6 cores in the same jar, like 6 cores from the right, 6 cores from the left. So if the cores are submitted in a way that each core can be identified separately, i.e. separate containers as we do right now, or color coded as some did before. In each, they used to put like a different color ink on each core. Then one should assign an individual Gleason score to each core. If multiple cores are submitted in one container and cannot be separately identified, and you find cancer in more than one core, then one should give an overall grade for the involved cores per specimen container. The kind of the saying that people say that if you have like maybe 3 or 4 cores, that like now we have all target biopsy, usually from one side they give you like about 3 or 4 cores. Think of them as one long core, and then see the amount of cancer there and give the average Gleason score to all of these cores as one core. Of course, these are the rules of the Gleason modification 2005. They had an impact on the practice of the Gleason grading system. As a direct effect of these modifications, Gleason 6 was very much diluted, because many of the original score 6 tumors shifted up to Gleason score 7, because the original Gleason had some allowed maybe some cribriform pattern in them, so that many of these shifted to Gleason score 7. Also, the recommendation not to diagnose scores 2 to 4 on core biopsy probably led many of us to kind of call them 3 plus 3, call them 6. So Gleason score 6 tumor became very indolent and very uniform. Also, literature after the ISUP 2005 reported that Gleason score 4 plus 3 tumors are associated with higher rate of biochemical failure after curative intervention than Gleason score 7, 3 plus 4. So 4 plus 3 is worse than 3 plus 4. Also found that Gleason scores 9 and 10 are associated with higher rates of recurrence more than Gleason score 8 tumors. And these studies paved the way for the creation of the grade groups that came later on and was adopted in 2014. Mainly the first study that came from Johns Hopkins after reviewing about 8,000 patients who underwent radical prostatectomy between 2004 and 2011, all of whom had complete biopsy data also, except 19 of this big number. So in the study, what they did is that they lumped the Gleason scores of Gleason score 6 or less, and Gleason score 3 plus 4 and 4 plus 3, and 8, whether it's resulting from 4 plus 4 or 3 plus 5 or 5 plus 3, and 9 and 10, 4 plus 5 or 5 plus 5. And then when they kind of did this Kaplan-Meier curves to correlate with biochemical recurrence-free survival, they found the biopsy Gleason scores or the prostatectomy Gleason scores correlated very well with the outcome. So they kind of suggested that probably we should create now a 5 prognostic grade groups. Like I said, Gleason scale 6 or less would be group 1, and then 3 plus 4 group 2, and 4 plus 3 is group 3, and 8 is 4, and 9 and 10 is 5. And the rationale is that patients with Gleason score 6 will be better assured about their prognosis when they are told their tumor is score 1 on a scale of 1 to 5, rather than your tumor is 6 on a scale of 2 to 10. When you say scale 2 to 10, so 6 would be like midway, and maybe it's even closer to the 10. So it's probably would be like a bad tumor. But now with this kind of clarification, or the descletonizing Gleason 6 became more akin to the Gleason scores 2, 4, and 5. So it went with them into group 1, and that will give the patient more assurance that their tumor is kind of more indolent behavior. And then came in 2014. Actually, the meeting was in 2014, and the paper came in 2015. So that's what they call it 2014, 2015 ISUP amendments of the 2005 modifications. And they came up with this pattern here, which is in comparison to the original Gleason and the 2005. You can see that here in pattern 3, they removed totally any cribriform pattern was removed from 2. They probably allowed some for the microcystic, maybe the pseudohyperplastic, and that was basically most of the and maybe also the branching glands here in pattern 3 or the grade 3. So any cribriform gland without necrosis is 4. Of course, if there is necrosis, would be 5. Glomeruloid is pattern 4 now, not left. They reiterate the grading of mucinous carcinoma should be based on its underlying growth pattern rather than grading them all grade 3, because sometimes you can see grade 3 carcinoma with mucinous extravasation, and if it's only not forming any cribriform, then it should be grade 3. But now don't take any mucinous carcinoma as a grade 4, again based on its basic pattern. Also, in between 2005 and 2014, there was papers about the intraductal carcinoma of the prostate. So this was also added here into this modification. Intraductal carcinoma without invasive carcinoma on core biopsy should not be assigned a Gleason grade. However, a comment to its association with aggressive invasive prostate cancer on prostatectomy should be made. At that time, also, urologists and oncologists did not know what's intraductal carcinoma. It took us some time to introduce it to them, and we used to write that kind of comment every time and every case had that intraductal carcinoma. But now most of them are aware of it, and even they ask us about it now. Is there any intraductal carcinoma or even cribriform pattern? And then, but this intraductal carcinoma was introduced, and at that time, it was, I think, most famous paper with that also from Johns Hopkins by Epstein, that he had like, I think, 21 cases that showed nothing but intraductal carcinoma on core biopsies, and then they underwent prostatectomy. 19 of them underwent prostatectomy. Most of them had high-grade, high-stage cancers in the prostatectomy specimen. So if you see that intraductal carcinoma only on core biopsies as evidenced by basal cell markers still there, then you call it intraductal carcinoma, and then give a comment about its aggressive, its kind of association with aggressive tumors in prostatectomy. Regarding morphologies of the following patterns, there was clear consensus on branching glands are still grade 3. Gleason grade 4 still includes the same pattern, cribriform, glomeruloid, fused, and poorly formed glands. And the term hyperinflammatoid was kind of removed. Don't use that hyperinflammatoid, but if you see that, which is a very rare pattern, it's not that common, it's pattern 4 or Gleason grade 4, or now ISUP grade 4. Said again, reiterate Gleason grade 4 pattern should be made at no higher than 10x. Occasionally seemingly poorly formed or fused glands among well-formed glands is insufficient for grade 4. So that tells you about these two cases that I showed you, that when some atrophic glands or some crushed glands at the tip, then this is not insufficient for grade 4, to measure grade 3. And the lower grade should be favored in cases with borderline morphology between 3 and 4, or for foci with crushed artifacts, that should be still grade 3. And now reporting of percentage grade 4 in cases that had mixed grade 3 and grade 4 is recommended. So 2014, there's still the recommendation, official recommendation is to recommend it to give the percentage of pattern 4 in cases with 3+4 or 4+3. So it's left to each individual preference. And they said small solid cylinders represent Gleason 5, as long as they show no lumens. And then also this rosette-like pattern, like this one here. It's not cribriform pattern, it's like some sheets or nests with this rosette-like appearance, is a Gleason grade 5. And then they said presence of comedonecrosis, even if very focal, is still pattern 5. And then they said that the grade group should be reported in parallel with the Gleason score. So this was a strong recommendation that after which we started reporting Gleason score followed by the grade groups. And even they introduced this kind of table here, in which very similar to the table that Gleason did for the Gleason system. And they gave the grade groups 1, 2, 3, 4, 5, and gave description to the glands and that you see in that system. And this was kind of a trial to maybe make this system more a new system independent of the Gleason scoring system. However, this one, as you can see, probably did not succeed till now, but we still use the Gleason scoring, and then we give the grade group after that. So we're still sticking to the Gleason scoring system. But I think this was an initial trial trying to maybe push this as a new system, as you can see in some of the applications here. Like came this publication after the 2014, a contemporary prostate cancer grading system, a validated alternative to the Gleason score. And this came again from mainly Johns Hopkins, as well as for some participants from Europe. And there had maybe more number of patients, about 20,000 patients were included in this study, in which also they repeated the same thing. And then again, the grade groups 1, 2, 3, 4, 5 shows the same kind of nice separation with recurrence-free survival. So in between, after 2015, around 2015, came this paper from 4 leaders in the field of GU pathology, Epstein, Amin, Reuter, and Humphrey. And they wrote this paper actually as an update with discussion on practical issues to implement the 2014 International Society of Urological Pathology Consensus Conference. And there were like mainly 4 topics that were dealt with in this paper here, kind of trying to maybe rectify understanding or kind of unify understanding of pathologists all around and how to apply this modification to the system. So recording percentage of Gleason 4, pattern 4 should be required, not just recommended. And grading grade group 2 and grade group 3 tumors with minor tertiary high-grade pattern, what to do with it, and if there is like 3 plus 4, 4 plus 3, and there is a minor or high-grade pattern. What's the overall grade concept and grading of multiple nodules with different grades in radical prostatectomy specimen? So they said when and why to report or not report pattern 4. They said currently there are different radiation therapy and hormone therapy approaches for Gleason score 3 plus 4, grade group 2, which is usually called favorable intermediate risk tumors, versus 4 plus 3, grade group 3, which is the unfavorable intermediate risk group. And usually there is difference in duration of administering the radiation and the dose of radiation, as well as the dose of the hormone therapy. Accordingly, they said reporting of percent pattern 4 is in all cases with all cores showing 3 plus 4 and 4 plus 3 should be required, not recommended. And that came the practice after that. And then even in cases that show a core with Gleason score 8 and the other core show score 7, you should report the percentage of pattern 4 in cores with Gleason score 7, as it provides useful information for the clinician. For example, if cores with 4 plus 3 showing 80% to 90% pattern 4, that probably would imply to the clinician that these cores are very close to being score 8 with 90% pattern 4, and they may treat them as maybe the unfavorable higher intermediate risk rather than the unfavorable, the favorable intermediate risk. The only way, in a situation in which you do not report percentage 4, is that when you have scores that show 9 and 10 score, because this one will be placing this patient into the higher risk group, and you do not need to report pattern 4 in this situation. And then if there is a high grade tertiary or minor pattern, what to do? So they said, although a specific cutoff of 5% was not voted on the 2005 or 2014 consensus meeting, the only quantification of minor high-grade pattern that has been used in the literature with evidence-based data was the 5% cutoff. So based on that, these recommended that the issue of reporting minor tertiary high-grade pattern in radical prostatectomy was not revisited in 2014 as amendments and was left to 2005 recommendation. So based on that, they kind of recommended the following. In prostatectomy with pattern 3, 4, and 5, in which 5 is the lower or the less in percentage, 3 is more than 3 and 4, and 5, in which 3 and 4 may be which one is higher than the other, but at least 5 is less than 3 and 4. And then they said if pattern 5 is less than 5%, should be reported as grade group 2 or grade group 3 with minor tertiary grade 5. If it's more than 5%, if it's 5% or more, then it should be included, should replace the secondary pattern. So it will be reported as 3 plus 4, rather than 3 plus 4 plus 5, more than 5%. No, it will be reported as 3 plus 5. What do it be? Oh, I mean, I'm sorry, here this I said, if it's more than 5%, but still less than pattern 3 and 4, will be reported as the primary and the highest. For instance, tumor with 60% 3 and 35% 4 and 5% on the cusp should be reported as 3 plus 5 grade group 4 rather than 3 plus 4 with minor tertiary 5, which would be a grade group 2. So you can see the difference in the grade group here is large. So if it's 5% or more, that kind of puts some kind of a strain or a stress on us when we have this kind of situation. Is pattern 5, is it 5% or less than 5%? This is kind of when it's more like 10%, 20%, it's easy, but when do you kind of say it's 5% exactly? However, in prostatectomy with 2 grades only, in which the higher grade is minor component less than 5%, such as in, like, say, grade group 3, I mean, pattern 3 is 96% and 4 is 4%, is reported as 3 plus 4, grade group 2. And then you mentioned that the secondary pattern is minor pattern that is less than 5%. And the recommended again is calling it grade group 1 with a minor pattern 4. So that's our recommendation at that time, because it's kind of less than 4%. I mean, less than 5%. So what's the overall grade concept? The overall grade for the case be that of the core with the highest grade, or should it be the average of all cores, or the most frequent grade? So that was not settled. I think the overall grade concept is is used more in Europe than in the United States. They said several studies have demonstrated that in cases with different cores having different grades, the highest Gleason score on a given core correlates better with the stage and Gleason score at radical prostatectomy than the average or the most frequent grade. So based on that, also they noted that urologists and oncologists in the United States usually use the highest Gleason score to determine prognosis and treatment. So if they say multiple cores are submitted from a specific site like MRI target biopsies, then the grade of the multiple cores in the same jar from that specific site are averaged together to report a single grade. But if you have separate grades, separate cores in different jars or color coded, then each one gets its own grade, which is re-emphasized the same kind of concept that was dealt with before, yeah. And then grading separate tumor nodules in radical prostatectomy, they said some studies have suggested that the smaller non-dominant nodules harbor the highest Gleason score in about 7 to 18% of cases. And other studies found that about 11% of cases, the highest Gleason score, the largest tumor volume, and the exophthalmic extension, or the highest grade, highest stage, do not occur in the same tumor, but occur in different tumors. So in such situation, they said simply just label them as tumor nodule number 1, number 2, number 3, and give separate grades and stage for each nodule without designating any nodule as dominant, because most of them are really dominant or significant, let's call it significant tumors that may affect the prognosis, because one has the highest grade, one has the highest stage. So these are significant tumors. And now in 2019, there was another consensus conference by ISUP to again add few things to, let's call them amendments to 2014 and 2005. And in that conference, this is the kind of the table from the paper that shows what they did in 2019. And then reiterated things again the same. That the said report in biopsies the percentage of Gleason pattern 4. So now they adopted that what came. So in this one they adopted many of the opinions that came in that expert paper by the 4 experts, and they said report the percentage of 4. It's a kind of a new mandate, and they called it in Gleason score 7, and they called it ISUP grade group 2 and 3. So those are the first time to call the grade groups, the new grade groups, as ISUP grade groups. And for radical prostatectomy include the percentage or the presence of tertiary or minor Gleason pattern 4 and 5, and if the Gleason score if constituting more than 5% of the tumor volume. Actually, here was that's in variance with the paper. I don't know if here the kind of some misprint or something, but in the paper by the 4 they said 5% or more, it should be included in the Gleason scoring. Here they say more than 5%. So in the papers, the cutoff was 5%, 5% or more, and less than 5% would be the just added as a minor. Do not grade intraductal carcinoma without invasive cancer, which is similar, but that was kind of still sticking with the 2014 amendments. But incorporate the intraductal carcinoma into the Gleason score when invasive cancer is present. Okay, and then comment again about the seriousness or the significance of intraductal carcinoma. They also added here, because some papers kind of said the cribriform pattern have maybe higher risk for recurrence. So they said comment on the present significance of invasive cancer, cribriform cancer. Okay. And there's about almost the same things that we discussed before. Yeah. The other thing that they said in target biopsies that are benign, what means false negative, that PIRADS 4 and 5, if there are some peculiar benign changes that may explain why this was on MRI was kind of portrayed itself as suspicious lesion for radiologists, if you see any benign findings in such cases, report them so at least they can make correlation. And then came the GUPS. The GUPS stands for the GU Pathology Society, was founded in 2018 as a split from the ISUP after some disagreement among the leadership of ISUP. I don't know what was the reason, but I was not attending in that one, and it was like one of the kind of the leaders of the society. So in 2019, ASCAP meeting did not host a companion meeting for the either ISUP or GUPS until the issues are resolved. So the 2019 ISUP consensus meeting happened in France in 2019 after the European Congress of Pathology. However, in 2019, during the ASCAP meeting, the leadership for GUPS unofficially met and to discuss the society and how this should approach important unresolved and emerging issues in prostate cancer grading. So GUPS formed teams that reviewed the literature and conducted international surveys of geopathologists, urologists, oncologists, and radiation oncologists. The results of these kind of activities came into this paper here, the 2019 Geopathology or GUPS white paper on contemporary grading of prostate cancer. Again, rather than going on the details of this paper, it had many similarities and few disagreements with the paper by the ISUP consensus. So came this paper here in 21 by Epstein and Kryvenko, in which they said comparison of the GUPS and ISUP guidelines. In which here, this at the top table here is the similarities and the differences in between GUPS and ISUP. So first thing that they had in this table was the nomenclature of the grading system. The GUPS still call it grade group, but ISUPs call it ISUP grade group. So they said although ISUP was influential in endorsing the grade groups and helping to establish its usage, it did not come up with the concept of grade groups or perform the validation studies, the two ones, one from Europe and one from Johns Hopkins. So the kind of this one of the disagreements. And they said Gleason pattern 4 in grade group 2 or grade group 3 if other cores have grade group 4, which we said that we said it in the paper by the 4 leaders, they recommend reporting the grade group 4 if there is one core that is an Gleason score 8. So ISUP had no position on that. And recording Gleason pattern 4 in how to report the percentage in either like grade group 2 or grade group 3, they recommend that to say pattern 4 either less than 5%, less than 10%, or 10%, and then in 10% increments after that, like 10%, 20%, 30%. But maybe the critical one was like 10% or less than 5%, less than 10%, and then after that, 10% and 20%. But ISUP had no position on that. Now, also, there is kind of a variance here, predominantly Gleason 3, pattern 3, or Gleason pattern 3, with a minor Gleason pattern 4 that we said less than 5%. GUPS would like to call this one grade group 2, adding 3 plus 4 would be grade group 2. However, the ISUP consensus was, no, still call it grade group 1 because pattern 4 is less than 5%, and then mentioned that there is a minor pattern 4. The same, similarly, also for the predominantly grade group or Gleason pattern 4 with some minor Gleason pattern 5. You call it 4 plus 5. Here you call it 4 plus 4, and a minor pattern 5 is present. They said here, enteroductal carcinoma with invasive cancer. The cell GUPS say don't grade or don't include the enteroductal carcinoma with the score or the grade in such situations. The best example is that if you have a core biopsy that is mostly 3 plus 3, and you have adjacent enteroductal carcinoma. So GUPS would say this is a 3 plus 3 grade group 1, and there is also presence of enteroductal carcinoma, and they give a comment about the seriousness of enteroductal carcinoma. However, ISUP says no, grade enteroductal carcinoma and include it in the grade. So this case will be for ISUP a 3 plus 4 or 3 plus 5 if that enteroductal carcinoma has maybe some necrosis. So that will make a big difference. Also, here is grade group 1 with enteroductal carcinoma. Here would be like grade group 3 or 2 or 3 or 5 even. So, and then say different scores in standard and targeted biopsy, assign a single global score. They said they have no position. I think there is a position here for ISUP, but I think this is probably look deeply into the ISUP population. But I mean, these are the main differences between GUPS and ISUP. So, however, this was not the last thing. Here's maybe the last study that came in 2024 from some of the leaders also from mostly Europe and Australia and New Zealand, and particularly with Lars Egvard, who was kind of the president of the ISUP Society at the time. They did the consensus conferences on how to handle prostate specimens. In the introduction, they said using population-based registry data from about 170,000 men diagnosed prostate cancer on needle biopsy, we recently investigated the outcome of Gleason score 8 to 10, prostate cancer with death due to prostate cancer or death from any other cause as endpoint. So they came up with this also kind of very nice graph saying mainly limiting this kind of Kaplan-Meier curve for the Gleason scores. Like here, this is I think 3 plus 5. You can see them here. These are the scores that constitute grade group 4 and grade group 5. And I think this one is here is 5 plus 5. Here is 5 plus 4. And this one, actually, there are two curves here. The blue one is 4 plus 5, and the burgundy one is 5 plus 3. And then this one is 4 plus 4, and this one is the 3 plus 5. And they said here that's kind of the death from prostate cancer specific death or mortality had nice separation here, except these two are kind of overlapping. And this is the overall death. So these two are overlapping here, which is one of them belongs to the, which is 4 plus 4 belongs to This one here is actually, this is 4 plus 5, it belongs to grade group 5. And this one is a 5 plus 3, which is 8, belongs to grade group 4. So that's what they said here. That's kind of, there was a prognostic heterogeneity between scores 3 plus 5, 4 plus 4, and 5 plus 3, which is grade group 4 and grade group 5. And this heterogeneity was lost when these scores were collapsed to just into simply grade group 4 and grade group 5. And there was a prognostic overlap for Gleason score 5 plus 3, which is grade group 4, and 4 plus 5, which is a grade group 5 cancer. So at least this one in between had very similar outcome. And although one of them belongs to grade group 4 and one belongs to grade group 5. So in their conclusion, they said the finding emphasized the importance of reporting the Gleason scores for more accurate prognostic information of the high-grade prostate cancers. It also questions the clinical value of the current recommendations of grouping Gleason scores into the ISUP grade groups. Okay. So this is actually from myself here. I said maybe we should now, it's time to have like a grade group 4.5, but I mean, whether these will have impact on patient treatment remains to be seen. For the time being, it's an interesting discussion among pathologists, but it's still the entire thing here is probably it's a high risk group, and the clinicians will treat all of these grade group 4 and 5 into high risk group treatment. And this is my last slide. Sorry, I went over time by about 3 minutes, but it's time now. If you have any questions, Dr. Tawfiq will kind of ask them. Thank you very much.
Thank you, Dr. Shabaik, for an amazing lecture and overview that everybody, I'm sure, will enjoy and keep it, particularly the people that are signing out prostates. I'm one of them, and I'm still struggling with a few of them and with the so many changes that are coming our way.
Yeah, what I always tell my residents that go to the CAB protocol for reporting cancer, and whatever in the CAB protocol, that's the one to use, and don't try to resolve it on your own, which one to use, ISUP or GUPS. Go to the CAB, because this is the one that everybody looks at it. Yeah.
Amen. That's what we're using.
Yes.
Again, thank you all. I know we went overboard, so
just 3 minutes.
Can I ask a question, please?
Because of the time for everybody, I would appreciate that you can reach out to Dr. Shabaik by email. I will provide you his contact information if you guys have any questions. And the last thing, we would love to hear from Dr. Khalifa about his knowledge about Dr. Gleason himself, because apparently he was at Minnesota at the VA hospital. So please share with us some fun information by email, Dr. Khalifa, when you have a minute.
Sure.
Thank you all, and I wish you all the best. And
thank you, Dr. Shabaik, for this very interesting lecture. And
thank you very much
Dr.
for attending.
This. Thank you, sir.
Thank you.
Okay. Take care, everyone.
Thank you.
Bye-bye.
Bye.